All right, good morning, everybody. Just want to invite and wish you guys, or thank you guys, I should say, for coming today to this webinar. Today we have Daniel Kwon from University of Southern California. He's on staff there in the Department of Head and Neck Surgery. He focuses on thyroid and parathyroid surgery, and he works both at USC Medical Center and at Children's Hospital Los Angeles. Daniel went to medical school at Loma Linda University and then completed his fellowship in Mount Sinai Hospital in New York City, which happens to be the same hospital where I did my residency. And so we have the unique pleasure of somebody with quite a bit of experience, and we're looking forward to the lecture. So thank you very much, Daniel, for joining us, and I'll give the floor to you.
Thanks, Dr. Wagner. Can you guys see my PowerPoint screen?
We're looking at it. It looks good.
All right, great. Thanks for the introduction. Hello, everybody. Thanks for having me to allow me to give this talk. I think Dr. Wagner overstated my experience a little bit. So, I'm still relatively early in my career. This is my 5th year out of fellowship, but thankfully I work at a place where we get to see lots of really interesting stuff, and hope to share some of this with you. And so, yeah, part of my background, I'm a head and neck cancer surgeon, but one of my focuses is thyroid surgery. And it was sort of a kind of a happenstance type thing where just by joining, the University of Southern California, which is affiliated with the Children's Hospital of LA, this just happened to be one of the bigger pediatric thyroid centers, in the nation. And so it sort of fell into my lap that pediatric thyroid cancer became kind of a significant part of my practice. And so I just wanted to share with you how we do things there, and just share some insights. And I'd love to hear anything you guys have to share as well. No disclosures. And so, when I talk about our thyroid team, everything we do is focused on a multidisciplinary approach. This is true at our USC Thyroid Center and our CHLA Thyroid Center. And so, it's not just surgeons doing surgery. We work very closely with endocrinologists. In fact, at our CHLA clinic, we actually have a true multidisciplinary clinic where there's actually 3 physicians and we all see patients together. But we work closely with the oncologists, the nuclear medicine folks, the radiologists. And so I think this kind of a collaborative approach really engenders better outcomes. At Keck, which is a university hospital of the USC, this is kind of our division. These are all head and neck cancer surgeons. Dr. Wagner, you might know Dr. Sinha. He was a fellow of, Dr. Erkin's one of the earliest fellows as well. And so, we all do thyroid surgery, but I sort of head up the thyroid program. The endocrinology team I work very closely with as well, the oncologist. And this is kind of our core children's hospital thyroid team. It's 3 of us. I'm sort of the cancer surgeon side. Dr. Austin is kind of the head, and she's a pediatric endocrinologist. And then Dr. Gomez is a pediatric ENT. And so in this talk, we'll just kind of go over the background of pediatric thyroid cancer, how we approach these children, kind of special considerations for surgery, that may be unique in children, and then, things like adjuvant treatment, follow-up, things like that. So just as, a quick background, you may be aware of much of this already, but, while thyroid nodules are, very prevalent in adults, they're not very common in children. Only a small percentage of children have palpable thyroid nodules or even detectable thyroid nodules, up to 18%, but a much higher percentage of these are cancer. And so, these are much more likely to be surgical patients. But even with that, because they're so rare, this is a relatively small cohort. While we do lots of thyroid surgery for in adults, I do maybe 200, 300 a year. In adults, in children, we're considered one of the busiest thyroid centers in the country, and we're still only doing about 40 to 60 thyroidectomies in children a year. And so there's obviously a huge difference. But when we get into sort of the adolescent, the teenage women, that's we see kind of rates a little bit closer to adults. It's much more common. Risk factors of thyroid cancer, this is what we all learn in sort of medical school. Of course, radiation exposure, family history, iodine deficiency. There's some question of if autoimmune thyroiditis may play a role. It's a bit controversial, but these are sort of the main risk factors. Obviously, radiation being the biggest factor. This is particularly relevant in children. Especially kind of at a children's hospital, you see all sorts of children with backgrounds, neuroblastoma, childhood lymphomas when they were very, very young. And so sometimes by the time they're even 18, they're already developing thyroid cancers. There's a whole host of hereditary tumor syndromes, and I have to admit, I'm not super familiar with all of these, but these are all syndromes that are associated with thyroid cancer, thyroid disease. And of course, there's the age aspect. Biologically, thyroid cancer is presenting in very young, like infants and things like that, are going to be much more likely to be some sort of hereditary cancer, such as medullary thyroid cancer. Of course, we all are aware of the MEN syndromes, and then as children get older into adolescence, they much more are closer to adults, in which we see differentiated thyroid cancers like papillary thyroid cancer. Thankfully, anaplastic thyroid cancer is extremely rare in children. And so when we sort of compare the approaches between adults and children with thyroid cancer, there's kind of a few guiding differences. I mentioned one already. Nodules are much less common, but much higher likelihood of malignancy. So really in any child, when we palpate a nodule or we see a large nodule on imaging, and the chance of having to do something about it, that is much, much higher. We rely on ultrasound characteristics more than size. And of course, this is because in a very small child, the thyroid volume is much smaller than an adult. And so a 6 millimeter nodule in a 4-year-old has a much bigger implication than a 6 millimeter nodule in a 50-year-old adult. We know that children have a unique pathogenesis. Even in adolescence with papillary thyroid carcinoma, you would think that's quite similar to adults, but we know that even differentiated thyroid cancer in children have a much worse prognosis than in adults. And so this is, with all the molecular testing and genomic profiling we've been doing over the past few decades, we've identified completely different genomic profiles in children compared to adults. Generally across the board, children are going to present with more aggressive presentation of thyroid cancer, meaning much more likely to have metastases, multifocal disease, lymph node, burden, and so this necessitates more aggressive surgical approach. And so the mainstay of thyroid cancer is, of course, surgery. And so that in an adult with a 1 centimeter thyroid cancer, it's pretty controversial whether we would do a central neck or peritracheal lymph node dissection. Whereas in children, it's it's much more common and much more likely that you're going to find disease in the peritracheal neck, even if imaging preoperatively is negative. Radioactive iodine, even though children present more aggressively, you would think that, okay, so they're more likely to get radioactive iodine. While that might be true, we do also have to be very careful and selective in how we use radioactive iodine because of the implications that radiation has on children. Generally speaking, we really try not to give it under the age of 10. But despite all this is improved outcomes, across the board, children do much better than adults, even with worse presentation. And so this kind of goes along with thyroid cancer prognosis in general. Outside of stage and histology, we know that age is the primary driver of long-term prognosis in adults, and this is true in children. I would say the main difference between how we manage children and adults thyroid cancer is just a lack of data. Like I said, thyroid cancer in children is relatively rare. The large data sets we have in adults, we just don't have in children. So a lot of the management guidelines are sort of borrowed off adult, information and studies and extrapolated, but that's why a lot of times any innovation we see in adult thyroid cancer management, we see at least like a decade lag before we see it get to children, just because we don't know if it applies. And so this is kind of an example is when you look at the American Thyroid Association pediatric guidelines, it looks almost exactly the same as the old adult ATA guidelines. So 2009 looked just like this, and this is what the pediatric guidelines currently look like. Of note, both adults and pediatric guidelines are due to change in the next few years, and so we may see, some significant changes to this, but we'll see. So when we evaluate these thyroid nodules, when we first discover them, whether they're incidental, so we feel a palpate a nodule, kind of the mainstay of, the first step in how we evaluate nodules is always high definition ultrasound. This is true of adults and children. And so for children, we really rely on ultrasound features more than size. And so there are several, ultrasound classification systems out there, the ATA, Thyroid, which is the American College of Radiology system that was partially developed here at USC. And then each country sort of has their own kind of set of guidelines, but they're all quite similar. And so, like I mentioned before, the size of nodules may not quite be as applicable in children. And so we rely on the features more so than the size. There have been several studies that compare the performance of adult grading systems in children, and there are some mixed results. So as sort of you would expect in older children, we see that the Thyroid system matches up pretty well and in approximating risk of malignancy, whereas in younger patients, it's not quite as reliable. And so, we actually are publishing a paper right now where we propose using a nodule ratio, where we form a ratio of the nodule compared to the volume of the thyroid based on ultrasound measurement. Kind of as a replacement measurement than purely nodule size. So usually, ultrasound is sort of the mainstay of treatment. We don't like to give radiation to children, but we still use MRI or CT scan if we're concerned for very invasive disease, bulky lymph node disease, things like that. We may consider chest X-ray or chest CTs if there's a high suspicion for pulmonary metastases. This is rarely done, even if in the presence of pulmonary metastases, generally most people would proceed with surgery unless it was an extremely advanced presentation. And so that's something to keep in mind. The next step after ultrasound, after we use the ultrasound characteristics, microcalcifications, hypoechoic, quality of the nodule, indistinct borders. Once we decide which nodules deserve a biopsy, then we turn to ultrasound-guided biopsy. I think basically everyone agrees that ultrasound-guided FNA is really the standard of care for both adults and children, but in children, again, this is even more so. In an adult, if you get a misdiagnosis on a biopsy, you can just do it again. And in children, these can be pretty traumatic experiences. At Children's Hospital of LA, we actually put every child under general anesthesia for their FNAs. And so, this might be a little bit overkill for, adolescents or, 13, 14, 15, they can probably do just fine. In fact, I've biopsied, teens in my clinic with ultrasound guided FA before, and they tolerated just fine. But, this approach does allow for us to get highly accurate results. And so because they're under general anesthesia, the interventional radiologists can take their time. They have cytopath technologists there to assess biopsies for adequacy, cellularity, things like that. And oftentimes they can give kind of a preliminary diagnosis on the spot. When we look at cytopathology, we generally follow the Bethesda classification system in adults. And so, I think the reason for that is just because it's the most well-recognized way of reporting cytopathology. But just like in ultrasound, the correlation in children to risk of malignancy is a bit mixed. And so, this is sort of the updated Bethesda classification system accounting for NIFT-P from 2017. We can see here for, category 3, it's, about, if you say NIFT-P requires surgery, about 10 to 30%, category 4, 25 to 40%, things like that. But in children, we see these rates are actually much higher. So this was a study done from Boston where they compared patients getting ultrasound biopsy at, I believe it was Harvard and the Boston Children's. And when they compared, we can see that in children, the rates of Bethesda 3 and 4 are much higher. It wasn't 15% and 40%, it's 44% and 71%. This is the adult rate in their population. So, fairly closely approximated what's expected based on the Bethesda system. And so, because this was sort of the same population of patients in Boston, you can kind of see direct comparison that in children, it's much more likely to be malignant. Sorry, this was at Brigham and Women's. So we actually did a similar study at CHLA. We did not have an adult, population to compare directly to, but when we looked at our rates, we actually approximated with the adult expected Bethesda rates fairly well, actually, 17% and 31%. The major difference being that a non-diagnostic biopsy was actually really high, 20%. And so, this is probably a little bit skewed in that, sometimes if you have a very large nodule, you get a non-diagnostic sample. In children, we're less likely to repeat it. In children, if it's a concerning enough nodule, then sometimes we would just go straight to surgery. So that number is probably a little bit misleading to some extent. In our population, we matched up pretty well with the Bethesda system. I'm not sure if this is because our cytopathologists are sort of reacting to the increased risks and, kind of describing them thusly. Some folks use the Bethesda system as a way of describing cytopathology. Some use it as a categorization system to match risks of malignancy. So, maybe further study will kind of find that out. But many studies have shown that in general, the Bethesda system probably has a little bit higher risks of malignancy for children than in adults. Molecular testing, is kind of the next frontier. Even when I was training a resident, this was very rarely done because it was very expensive and it was still very early. These companies, these are sort of the 3 main companies here in the United States that are approved. It's probably different in other countries in Europe. But these are becoming more and more common. And in adults, it's almost routine at this point. If you get a Bethesda 3 or 4 nodule, then you send it for molecular testing for some more information based on the genomic profile. There have been several studies in children which show this is pretty pretty useful in children as well. But it's just there aren't that many pediatric nodules in their databases to make this really accurate. Essentially, how these work is, all these companies have really large databases of molecularly profiled tissue. And so they can basically, their algorithm can compare the profiles of a new sample to all their old samples. And so simply because we just haven't used this in children very much, we don't have much to go off of essentially. So when we go to surgery, and so many of these children end up having surgery, kind of the main principles is we want to maintain good outcomes. The thing to keep in mind is that almost no matter what, these children typically do well. These children are, expected to have an extremely high survival rate, 98, 99%. So we want to maintain that while at the same time avoiding complications. So whenever we offer surgery, everything we do is either over treatment or under treatment, right? And so back in the day, anytime with any lymph node, cancerous lymph nodes, we would do a radical neck dissection. Well, these days now we do things called selective neck dissections or modified radical neck dissection. So in that same way, we're sort of trying to improve the quality while still maintaining the good outcomes. And the main, I think the reason why to kind of think about this more in children is that obviously paralyzed cord, a bad scar, permanent hypoparathyroidism, the impact of this is much more in a 10-year-old who has to live with this for the rest of their lives versus a 60-year-old. Not that it isn't important in both patients, of course. This is a photo of me doing kind of endoscopic guided thyroidectomy here. And so, the technique is obviously quite similar to adults. We don't really do anything too much different. There are some additional pitfalls that I'll mention. And we're seeing sort of the trends. This is actually pictures from my surgery, which, the endoscope shows things pretty high definition, so it's pretty nice. But, we're seeing the trends following adult kind of trends. Kind of the biggest, sexiest thing right now, of course, being transoral thyroidectomy. And before, we see in Asia and in some centers in the US is gaining popularity. At first I was sort of doubtful. I thought this was kind of like transaxillary thyroidectomy, which would kind of come and sort of fade. But it seems like this is kind of around to stay. And there have been some series published on their experience in children. And so if I were to guess, we're probably still going to continue in that direction, at least to some extent. Some, pitfalls of surgery, thyroid surgery in children is just kind of a little small things for anatomy that it's a little bit different. And so one of the things that we noticed in our experience here at CHLA is really the high prevalence of thymic tissue. And so this is something that's been described and something that we've actually studied, and we went back and looked at it. And in our population, about 25% of children getting thyroid surgery, we noticed thymic tissue kind of, like within the thyroid bed. And so this is a great picture. I thought this is, I don't know, a few months ago, this is a thyroid lobe we're removing. We see the recurrent laryngeal nerve here. This is a partially devascularized para. And this is all this thymic tissue. And we'll see a glob of thymic tissue here. And so this is way up in the, tracheoesophageal groove in the thyroid bed. And so this can be easily mistaken for lymph node disease. You can see that it's right overlying the recurrent laryngeal nerve. And so this is just a bit of a pitfall to not get too confused. Of course, in children, central neck dissections or peritracheal dissections are much more common. We try not to use any drains or non-absorbable sutures just to spare the children of, any trauma down the road. This is actually a video of a thyroidectomy. You might wonder, what are those things on the skin? That's actually Steri-strip tape. It's because we use the harmonic scalpel. I don't know how available it is other places. It's a fairly expensive instrument, but we use a harmonic scalpel. I like to avoid using clips and things like that. That makes ultrasound surveillance down the road much easier. And so here, this is just a standard thyroidectomy. Here we can see us taking down the superior pole of the right side. the landmarks being the carotid artery on the right tunnel and the cricoid on the left. And so we're taking down the superior pole while we're sort of retracting the upper lobe of the thyroid down and out. Now that we've kind of medialized the thyroid lobe, we're taking down sort of the lateral attachments. While we take down these attachments, the next step we'll be looking for the nerve in the tracheoesophageal groove, which I think we're probably going to see there. There we see the nerve. This is using a McCabe dissecting instrument, which is one of my favorite instruments to use. Again, using the harmonic, which is great. It seals all these vessels without using clips. Of course, there's nothing necessarily wrong with using clips or ties. This is just kind of the way I like to do it. But that's, and then obviously we take down the rest, sparing the parathyroids, etc. So, one thing we sometimes use is frozen section analysis for indeterminate cytology. So, say we get a Bethesda 3 cytology back for a child with a large nodule. Sometimes, instead of having them undergo general anesthesia again to try to do more sampling, just because, and also just the trauma of having 2 separate surgeries is a lot in a child. Sometimes we can check the lobectomy with a frozen, and if there is a presence of cancer, then sometimes we opt to do the completion thyroidectomy right then and there. This is something that has limited utility. You need to have a lot of buy-in from the pathologist. A lot of pathologists don't like this because, especially if it's a follicular nodule, they're not going to be able to tell you if it's cancer or not. But once in a while, you see a papillary thyroid carcinoma that just wasn't able to be diagnosed on cytology, and we're able to prevent a second surgery in some of these children. One other thing we use is recurrent laryngeal nerve monitoring. Now, this is something that I do not do routinely in adults. Many people out there do this routinely for all their patients, but for the children, at CHLA, we do this. This was a long-standing tradition before I ever got there, and so I've just kind of continued this. And so we generally use the Medtronic NIM tube. If it's in a smaller child, we have to kind of jerry-rig smaller ET tubes. And so, the guidelines don't say that you have to use nerve monitoring, but they recommend it for high-risk cases and things like that. And so this is something we use, for every child getting thyroid surgery at CHLA. We do have a neurodiagnostics person in the room monitoring this. And this is just, it's kind of one of those things that, when you're at a children's hospital, they tend to kind of go above and beyond and do all these things that, I wouldn't necessarily do in my own adult practice, but, it's for the children. So when we look at sort of complications, the obviously hypocalcemia, hypoparathyroidism is one of the main things we consider, especially because most of these children are getting a true paratracheal dissection. And so the numbers in the literature range widely, and I think that's probably because there aren't that many really high volume pediatric thyroid surgeons out there. And so we see numbers from the teens to the majority of patients. I think our rates are about 30%. But really, I think that the transient hypoparathyroid rates are not that. I don't really consider this an adverse outcome. If you do a true, very extensive paratracheal dissection, you're almost expected to get some level of hypoparathyroidism. Now, permanent hypoparathyroidism is obviously an outcome you really don't want to see. And so this is thankfully much lower, about 1 to 2%. These children are going to be dependent on calcium and or vitamin D long term. The couple cases I've had is quite, to me, it's one of the worst outcomes, to have patients having tetany and needing to take lots of these medications long term. But it's just sometimes you see them, and interestingly, sometimes we save parathyroid glands, but they still become permanently hypoparathyroid, and so sometimes it's difficult to predict. And so obviously just positively identifying them, preserving the vascular supply. If there's any question, and this is something I've learned over the past few years, is if there's any question of these being overly devascularized, meaning they turn black in the field, something like that, I will oftentimes just take it and reimplant it in the muscle. I think that's probably better than just leaving a devascularized gland just kind of floating in the neck. And so, I think the rates in children are higher for incidental parathyroidectomy. This is another study that we did, and this kind of goes along with the presence of thymic tissue. As you know, parathyroid tissue has the same embryogenesis as the thymus. And so we see a more variable, at least in our experience, a more variable location of the parathyroid gland. And so this is something to watch for if you're ever doing a thyroidectomy on a child, is the parathyroid glands are not necessarily in the same kind of areas that you might expect in an adult. We see higher rates of intrathymic or sometimes intracapsular parathyroid. This is an example here. This is in a child, and this is thyroid lobe. And I hadn't seen the inferior parathyroid yet, but I noticed a small hue in the thyroid, so I cut open the thyroid, and within the capsule we see this parathyroid gland here. And so I think just because these are still developing children, I think the location and presentation of these are a little bit more variable and tricky than in adults, and the data, the literature supports this. The post-op calcium regimen is quite similar to adults. We do it based off of a parathyroid hormone. Thankfully, we have a rapid PTH assay in our lab, and so we sort of use this to help guide the level of calcium replacement. And then, of course, we trend these. In our experience, we keep children getting total thyroidectomy and paratracheal dissections overnight. This is different to adults, where I would say about 80 to 90% of patients getting a thyroidectomy for cancer tend to go home the same day. And this is pretty common. This is the trend throughout adult sort of kind of high volume thyroid cancer care. But in children, we still watch them, we trend their calciums, and we adjust it. Thankfully at CHLA, this is kind of our protocol. At CHLA, we're lucky to, as surgeons, we're very lucky to have actually an endocrine hospitalist team. So after surgery, we can admit to the hospitalist team, and they kind of take care of all this for us. And so this is one less thing that we have to sort of worry about. So, when we talk about post-operative cancer care, we look at the pathology results. We say, okay, now that the surgery is done, what else do we need? And so, the ATA has a 3-tiered staging system based on our pathologic staging. Basically, intrathyroidal tumor, minimal metastases, extensive metastases, or a cancer that's coming out of the gland, or with distant metastases. And so, post-operatively, many of these patients undergo a thyroid scan and thyroid ablation with radioactive iodine. As I mentioned, this is something that we have to carefully consider based on their age, but because many of these kids have just a more advanced presentation, many of them end up having the scan. Again, we also use thyroglobulin extensively to track these. There are differing approaches based on this, but some people would restage the patient based off of a thyroglobulin assay done about 1 month to 2 months after the surgery. And you can imagine, nothing else in the body makes thyroglobulin. And so, if you draw thyroglobulin a month, 6 months out, and it's undetectable, then you can make a pretty good argument that you can observe that patient, even if they are, no matter what their disease presentation was. This is sort of the algorithm in how these patients are treated. This is generally kind of the decisions made by the patient, parents, and the endocrinologists. And so, radioactive iodine, just a quick comment on this. I think a lot of people have some confusion on the role of radioactive iodine, and I think a lot of this is controversial. But it was historically used for remnant thyroid ablation. Now, two other kind of main uses for it: treatment of distant metastases, and then the third one is, kind of an adjuvant treatment. And so the role of that is much less clear. And so, for something like a squamous cell cancer in the head and neck, we use radiation commonly as adjuvant treatment for things like extranodal extension or perineural invasion, because we say, okay, there's cancer cells kind of escaping, it's in the soft tissue, it's in the field, and we want to kill those cells. There isn't very much evidence that radioactive iodine actually works in the same manner. And so we know that it works great for thyroid ablation. We know that it works great for metastases, but it's not really that well established that it works for adjuvant treatment or sort of cleaning up cancer cells. Also, there's scant evidence that it's useful for lymph node metastases. And so this is kind of a very gray area that you'll probably see different endocrinologists or different surgeons kind of have very different takes on this. I think the main thing is to have kind of a very good discussion with the care team and the parents to kind of weigh the risks and benefits. The good thing is, for even, advanced distant disease, generally, a lot of it can be treated very well with radioactive iodine. Based on the literature, we see complete responses in close to 50% of some of these children, which is great. Of course, there's a subset of patients where may not be iodine avid or just don't respond to radioactive treatment. Again, we are selective on this because of the long-term potential side effects of radioactive iodine. It's much less morbid than external beam radiation, but it still has several short-term and long-term morbidities. Thankfully, I think radioactive iodine traditionally was thought to really diminish fertility. And so this was something that long-term fertility. And so this was something that was kind of a really big concern. Most of the more recent literature shows that that's not necessarily the case and that fertility should recover. But certainly it's something to keep in mind. Now, in adults, with thyroid cancer, we practice TSH suppression almost routinely. And so the idea being that when we replace the thyroid hormone levels, we do it at a supratherapeutic level. And so that your pituitary gland, your TSH is suppressed. And so that any remnant thyroid tissue, thyroid cancer is getting the signal to shut down. In children, we're a little bit less aggressive on that, and that's just because, as you may know, having hyperthyroid levels for a long time do have some side effects. It can accelerate osteoporosis. It can, cause or contribute to heart failure, things like that. And so, in adults, we sort of kind of try to thread the needle in what's, suppressed but not overly symptomatic. And generally, after about 5 years or so of being, in remission or being stable disease, many people will back off. In children, we're a little bit more hesitant to use it just because, especially if you're not fully developed, there's the data, especially from, we get this from the Graves data, children with Graves disease, we see things like, poor, cognitive development, poor bone health and skeletal development, while, TSH suppression hasn't directly been linked to any of these. These are just some of the side effects we know of when children have overt hyperthyroidism. So it's something that we just try to avoid as much as possible. When we do monitoring, as I mentioned before, we use thyroglobulin antibodies. Unfortunately, it's quite prevalent in children. About 25% will have thyroglobulin antibodies, which of course makes following thyroglobulin much more difficult. And the reason for that is if your body produces antibodies to these to thyroglobulin, then we can't use that test as a quantifiable test. We do periodic ultrasounds, 6 months after surgery to look for any structural disease. And then after that, it's spaced out. Generally, whole body scans would be for folks with high risk disease, folks who had metastases that we want to monitor, things like that. And of course, in rare cases, we would do things like PET scans. There's evidence that when thyroid cancer loses iodine avidity, then it tends to be more PET positive. But this is thankfully relatively uncommon in children. For recurrent residual disease, generally speaking, 1 centimeter is my cutoff to go back into someone's neck to remove cancer. It really depends on what this is. If you have a recurrent cancer and it tends to be right at the cricothyroid joint near the larynx, the risk of that developing and invading into there is much higher than one just kind of sitting in the lateral neck. And so, but generally, if it's less than 1 centimeter, then it's oftentimes pretty tough to even find in the surgery. And so oftentimes, very small disease will monitor. Some people have described using radiofrequency ablation or ethanol ablation. This is not something that's very commonly done, but is described, and it may be more common where you guys practice. Chemotherapy, immunotherapy, this is thankfully very uncommon, and most of them have not been studied in children. There are a few trials treating some of these agents in children, like the kinase inhibitors, like lenvatinib, but this is not well established. And so, going back to the quality of care, in adults, kind of more recent publications suggest that sort of high volume threshold for a center or a surgeon is 100 cases per year to really start seeing higher quality outcomes. In children, that's kind of more like 30. And so thankfully, we squeak by and we qualify here at CHLA. This is one of the recommendations of the American Thyroid Association that generally, if you have a child with thyroid cancer and you can refer them to a kind of a high volume center, that's what you should probably do if that's feasible. In our case, as I mentioned, we practice a true multidisciplinary clinic. We actually have a monthly multidisciplinary thyroid cancer conference. This is by surgeons, endocrinologists, radiologists. We review each children's case. And so I think this all sort of contributes to higher quality outcomes. Our surgery is pretty unique, actually. We actually practice 2 attending surgery for these children with thyroid cancer. So, a thyroid cancer, like a medullary thyroid cancer or a pretty advanced papillary thyroid cancer, these are actually quite technically challenging surgeries. And so we think that while it's not the most productive necessarily for times, we think that these children deserve the attention of 2 attending surgeons. So in our practice, I do these surgeries with Dr. Gomez, who is pediatric ENT, who kind of specializes in tumors. At first we wondered, is this kind of a waste of time? Is this, maybe a little bit overkill? But, we actually, in our own database, we looked at outcomes when we start doing 2 surgeon surgery versus back in the day when it was just 1 surgeon doing it. And we were able to see that, we are able to cut down on time. We're able to decrease complications, have shorter hospital stays. And so we think that's worth it. And that's what we're still doing. We follow these patients in our thyroid practice long term before sort of handing it off to just pediatric endocrinology. And this is sort of the data that demonstrates that we see measurable, statistically significant decreases in complications when you have folks who do a lot of thyroid surgery doing these surgeries. This is actually in adults, and so this is low volume, intermediate volume, high volume. This is, I think, less than 30 a year. I think this is 30 to 100, and it's over 100. And so in summary, pediatric thyroid cancer, if I'm being honest, the mechanics of treatment, workup, everything are quite similar to adults. But you know, this is a unique disease process, and there are several kind of you know, unique aspects of it, unique aspects of the evaluation treatment that are all pretty particular. And so having a focus on it, I think, with a team lends itself to improved outcomes. And you know, having a higher volume improves. And the main thing is we need a lot more information before we can really have a separate guidelines for children. So thank you for letting me give this talk. Maybe outside of COVID times, some of you guys can visit us here in LA.
Daniel, thank you very much for this very comprehensive analysis of thyroid disease in children. I got a couple questions. Number one is, how many cases annually are in the United States? Do you know?
For children, I actually don't know that.
Would you say 1,000 or more?
I don't know that off the top of my head. I would probably say around 1,000, you know, and that's just kind of extrapolating from, so, you know, we talk to lots of other kind of high volume, you know, pediatric cancer centers like CHOP in Philadelphia, San Francisco, Texas Children's, and we're all doing about, you know, 40 to 70, kind of the major thyroid hospitals. But it's just like adults, you know, where actually the majority of surgery is done outside, you know, kind of these main centers. So we have to imagine that we're sort of the minority actually overall. And so, yeah, probably at least 1,000, I would think.
And then what's the youngest child you've seen thyroid cancer in?
I think it was, I mean, obviously we sometimes do the prophylactic thyroidectomy for children with the MEN syndrome. But I think the youngest was 4 in my experience. But I think that was a medullary cancer.
Okay. A couple more questions, because this is something I've been interested in. Have you seen anaplastic thyroid cancer in anybody under the age of 10?
No.
No. Okay.
Yeah, we were just talking about this the other day, and we were looking through our database, and we couldn't find any actually.
Okay. The other thing is, you said you did your fine needle aspirations under general, but then I saw a slide that said something like 83%, but then the slide faded away. What about using ketamine?
I don't actually. So, you know, at CHLA, the interventional radiologists do it, and so I don't know actually what they use. I do think they actually intubate these kids, and I will say personally, I think it's a bit overkill. And so I always run into this being an adult surgeon mostly who goes over to the children's hospital, where I sort of roll my eyes because, like, I think half the stuff they do here at the children's hospital is like definitely overkill, but that's how they do it, and I'm pretty sure they fully put them to sleep with the tube. So yeah.
Okay. And then there were 2 other things, and we have people who have joined us in the lecture today from both Ethiopia and Ukraine. And there's a significant amount of iodine deficiency because in Ethiopia, and I'm referring to here, Ethiopia has a significant amount of goiter. Now, I'm not sure if the colleagues from Ethiopia that are online with us today are more general ENT, if not otology oriented, but if they do have any experience dealing with thyroid disease in children, please make a comment. And I'm going to say the same thing. So I guess Nega or even Aziz from Somaliland is with us today. Do any of you see any thyroid lesions in children? If they don't respond, I guess.
Richard.
Yeah, hi, Nega.
Yeah, I have never met a patient with thyroid disease.
Okay,
thyroid in children.
Yeah. Okay. Nega's from Addis Ababa, and he doesn't see children. Okay. Aziz, Somaliland, Aziz. Aziz, do you have any experience with lesions in the thyroid in children? Let's see if he's still there. All right, no problem.
I also wonder, I imagine, the practice patterns may differ, regionally. Even here in some centers, general surgeons treat the majority of thyroid disease. Where we are, ENTs are treating it, but it might be different, of course.
Right. The other thing is in the Ukraine, the colleagues, we have a few colleagues online now from Ukraine. The Chernobyl incident, I think in the early 80s, I think it was, almost 40 years ago, had a significant impact on adults who had thyroid cancer development. I'm not sure if I don't think they weren't born, first of all. But I guess the question is, it would be more back to you, Daniel. Have you seen has there been anything in the literature on thyroid carcinoma in children who were exposed to the Chernobyl nuclear disaster?
Oh yeah, definitely. There's actually several papers on that, and there was definitely an uptick in cancer. It was actually mostly seen in adults, because obviously there is that sort of 15-year lag time, and so most of the patients developed it were adults when they presented. There's also kind of smaller, that's obviously a pretty dramatic example, but there are smaller examples like in Pennsylvania. I forget the nuclear reactor there, but they had an accident, and so they have a
3 Mile
higher
Island.
incidence of cancer. What's that?
I think it was 3 Mile, or was
Yeah. And so I think there have been some public health studies based on that as well. And so
right.
there's
Then we have the recent one in Japan,
yeah,
Nakashima, okay,
yeah.
which I'm sure they're doing studies from an epidemiologic and public health perspective as well. Okay. The floor is now open. I've asked my questions. Does anybody have any further questions? This is kind of a unique topic. I also know Jonathan Russell.
Yeah.
I'm sure you know Jonathan. He's one of the pioneers, I guess you could call it, in transoral approach to thyroidectomy. All right. Any questions? Oscar, do you have any questions? You've been kind of quiet lately. Oscar's not here anymore. That's why he's quiet. Okay. All right.
Yeah. This is sort of a
All
niche.
right.
It's sort of a niche topic, and so when I was telling you the kind of the lectures I sort of had ready to go, I was surprised when you picked this one, but I guess that's good too. It's one of those things where you read about more so than see. So
Right. And then there's a guy, I got a friend at MD Anderson. What's Mark Zafario? Mark, you know Mark?
I don't know him, no.
Yeah, you should connect with him through Jonathan. They're good friends. I know both Mark and Jonathan well. And he does a lot of stuff with thyroids. I think he's head of their program down there.
Okay, yeah. I know John Russell, and yeah, you're right. It's crazy how he's kind of become this leader in this transoral, and we're actually the same year. We're the same year, and he's kind of seen as a leader in the field. So what he's been doing is great. I went to his course also at Hopkins. So
very cool. Okay, well, listen, if there's no further questions, listen, everybody, thank you, but especially Daniel, thank you for sharing a unique topic with us. I mean, I did my residence, as I said, New York City at Mount Sinai. I don't think we ever had, we did probably 5 thyroids a week, but never saw in my 3 years of training, ever saw a kid, ever.
Yeah.
In a big metropolitan, practice, academic practice. So anyway, listen, continue on well with your program. It sounds really inspiring. It's a great place, a nice niche, and all the best to you. And again, thank you for your time today.
Thank you, everyone. Thank you, Dr. Wagner.
You're welcome. Thanks again.
Bye-bye.